Hello, this is Dr. Bhaumik. Welcome to the Part 2 of Metabolic Disorder lecture. We just finished the Part 1. The reason I wanted to divide in two parts because it is too long. And again, as I have mentioned in my first part lecture, that I have made a little bit changes in the sense that I have put lots of information in slide. And I would rather respect that if you are following this lecture, you can collect those slides and get the content from the slides and put it together. That will be your note. And I feel very comfortable that will help you to get the general knowledge that you need to know about the subject and also help to do well in your USMLE 2 and 3 or your pediatric board examination. I have designed this lecture for a senior medical student, pediatric house staff, general pediatrician, or anybody who is interested in this group of disorder. So Part 2 is actually very important, and that you are going to see or identify in your newborn nursery or in the clinic. Although you will be referring this patient to the specialist, but identification initially will be done by you. And the disease that I'm going to talk to you, it itself could be a full lecture length. However, I have provided you what I call as a dime version of the lecture and what you really need to know. So without further ado, let's move on to the lecture. Today's first discussion is going to be galactosemia. Any pediatrician or pediatric resident that rotating through the nursery or in the clinic are very familiar with this condition, at least learn about the galactosemia. And it is an autosomal recessive disorder, and there are three kinds that because of the three enzyme deficiency. And here I have mentioned about the most classic one, and which is galactose 1 phosphate uridyl transferase, and that's the classic one and most common one. And the second one is what we call galactokinase deficiency. Some people call it Duarte variants, and this is the milder form. And third one is isomerase, as next diagram will give you a little bit idea. And it should be suspected with any children, any newborn with hypoglycemia and enlarged liver. And one of the things that this metabolic disease or defect affect all ethnic groups equally. So there is not that one group is more vulnerable than other. It is like all ethnic group. And it is about 1 in 40 to 50,000, but there is no specific number that I can tell you. And this is a very good diagram, and that if you follow through, I'm going to show you. And this is how you use galactokinase, galactose to galactose 1 phosphate. So deficiency of galactokinase, this is the milder form, and this one is usually less common. Then the classical one is right here, galactose 1 phosphatase uridyl transferase. And this one you can see right here, as this is the most classical one. And then there is another one, as I call epimerase, UPD, galactose epimerase, is very rare. It's just I'm mentioning for academic interest. And the clinical presentation is interesting. The symptoms begin after feeding the milk-based formula as well as breastfeeding. So therefore, breastfeeding is not a panacea for this condition because breast milk also contains galactose. So once you start this formula and you see that the patient present with vomiting, diarrhea, bloating abdomen, gas, failure to thrive is very common, and the important finding is jaundice and cataract. Remember, the cataract is present in galactosemia. It may not be evident right away, but as the time progresses, you might be able to see. So the cataract in galactosemia is something important association, and you should remember that. And there are also renal tubular acidosis, and cirrhosis of the liver can occur if the patient remain untreated for a longer period of time. Another very specific point I want you, for your examination purpose, to remember that this group of babies are very susceptible to E. coli sepsis. So mark this one, this is important for your board purpose. This newborn with galactosemia very susceptible to sepsis, which is by E. coli. And the next one is also equally important. If the galactosemia patient is at puberty, having problem with menstruation, or clinical picture and hormone picture looks like primary ovarian failure or early ovarian failure, and that also occurs in galactosemia. If the control is better, prognosis or chances of having that problem is less, but remember that cataract, E. coli sepsis, and ovarian failure in a female. And therefore, the one should start treating them with soy formula or element formula. And the urine, the one of the very quick way of making the diagnosis is urine will have non-glucose reducing substance. But this condition should be diagnosed or confirmed by the enzymes assay in red blood cell. And the prognosis is actually very good if they are treated early. And this is another one comes called hereditary fructose intolerance. Enzyme deficiency here is fructose 1-phosphate aldolase B deficiency, and classically the symptom will start after introducing the fruit juice or applesauce, bananas, all this food that you introduce, and that could be around 6 months onwards, and that's about time you introduce the solid food. And they will present immediately with vomiting, diarrhea, flatulence, severe hypoglycemia. Severe hypoglycemia, and they may have even seizure. They mimics like galactosemia. The management is obviously avoidance of fructose, sucrose, and sorbitol. Many of these hereditary fructose intolerance are very milder form, and they usually have a little stomach pain and gas, and they themselves know to avoid some of the food that might give them problem. So therefore, this one is treatable condition, but one need to identify and response accordingly. And among the glycogen storage disease, the most common, there are 1, 2, and 3 types, but most of the common type is type 1, and which is also known, is time-honored name is von Gerke's disease. and that's also that's called type 1. It is autosomal recessive and only hepatorenal involvement. Liver and the kidney is involved, and this is due to the deficiency of glucose 6 phosphatase, the enzyme glucose 6 phosphatase, and the finding will be hepatomegaly, large kidney, and severe persistent hypoglycemia with lactic acidosis. One will be surprised to see that this patient is walking and talking with a blood glucose of 30, that low, which is so it is a chronic hypoglycemia. The body has learned how to deal with it, but they are very severe. At the same time, they have high uric acid, high triglyceride level, and they develop gout because of the high uric acid level. Very vulnerable to develop hepatocellular carcinoma, and the management obviously is going to be frequent feeding with complex carbohydrate. At night, the people have used corn starch to prevent significant nocturnal hypoglycemia. So type 2 is the Pompe's disease, which is a second one, and it is also autosomal recessive, and enzyme deficiency is alpha glucosidase in this case. They usually normal at birth. They usually present few weeks after life or months after life. They present with marked hypotonia, and they involve heart. So this is important, that they have a severe cardiomegaly, marked hypotonia, moderate hepatomegaly, but normal mental development. Prognosis, unfortunately, is not very good. Okay. So glycogen storage disease, Pompe disease involve heart. So this is a little bit different, and prognosis is not as great. Now we are going to come to a group of disorder which is very uncommon, and I'm just mentioning them for the sake of general information. The disease usually present. In order to make the diagnosis of the disease, one need to show that 3 or more organs are involved with the process. The most common one, and the people know about this, is Cartier syndrome, where there is ophthalmoplegia, pigmentary degeneration of the retina, and hearing loss. Also have heart block and neurodegeneration. And this is a mitochondrial disorder called Cartier syndrome. Then the MELAS. MELAS is called mitochondrial encephalopathy with lactic acidosis and a stroke-like episode. And this is a very special situation and is rare, has to be managed by the specialist. Now, next we are going to move on to a very special group of disease called lysosomal storage disease. Let's think about the lysosome is a little sac inside the cell which contains the enzymes, which breaks down the complex carbohydrate and the fat part into the smaller particles for disposition. And absence of the enzyme will prevent that process. Therefore, what will happen that they will accumulate inside the cell and will make problem. See, most common and very dangerous one is called Tay-Sachs disease. And this is autosomal recessive, and this condition is due to the deficiency of hexaminidase A deficiency, which is identified which could be identified in the leukocyte and the fibroblast. And one of the things that very interesting to see that they have a very startled response. So even in the newborn period, if you go there and put a little sound or like that, they will have very startled uh, response and very, very sensitive to sound. And for the purpose of your examination, Tay-Sachs disease has cherry red macula. The eye finding is the cherry red macula. They have macrocephaly, progressively develop blindness, seizures, severe developmental anomaly. They usually die early. There is another form which is not as bad as the infantile one, and that's usually we call juvenile form. Uh, Starts after 2 years of life, and they do not have cherry red spot, and they have chorioathetoid movement dysarthria, but the prognosis is a little better than the original infantile form. This is a very nice diagnosis diagram that I can show you that if you just follow this diagram, let's look here. And this is a cell membrane, and this is GM2. We have got two monocyclic, M is monocyclic acid and ganglioside, and here it converted to glucocerebrosidase by an enzyme called hexominidase and hexominidase A, and absence of this enzyme will give you what we call Tay-Sachs disease. All right, let's go to the next one, and this is glucocerebrosidase, and this enzyme deficiency will give you a condition called Gaucher disease. And then here is the sphingomyelinase, and absence of this enzyme sphingomyelinase will give you the Niemann-Pick disease. Okay, and so if you just look at this diagram, and this is beautifully what is the deficiency and what is the buildup. What is the buildup of ganglioside? Now let's look at the Gaucher's disease. This is the more common one, and you have a deficiency of enzyme, as I showed in your last slide, is glucocerebrosidase, and it is autosomal recessive. And this patient present with very large spleen, liver. They have significant bone pain with leukopenia, thrombocytopenia. If you do the bone marrow aspirate, and which is also one of the diagnostic procedure, and also the spleen biopsy will show the characteristic Gaucher cells, and they are nothing but ingots with glucocerebrosidase, and also known as wrinkled tissue paper. An X-ray of the distal femur will say flash-shaped changes of the long bone, and treatment with enzymes replacement has been pretty promising. The next is Niemann-Pick disease. This is autosomal recessive, and enzyme deficiency is sphingomyelinase, and you have hepatomegaly, mental retardation, and also you have cherry red spot. So Gaucher and Niemann-Pick both have cherry red spot, and bone marrow will show the foam cell in the bone marrow. A peripheral blood smear also will show the same kind of cell, and it is due to the sphingomyelinase deficiency in WBC, fibroblast, or other tissues. And enzyme replacement is tried and being tried as far as prognosis is concerned. The present time is not that great. This is a beautiful diagram of cherry red spot macula, and it you can see is Niemann-Pick disease and Gaucher's disease. Now, the next group of lysosomal storage disease is rather complicated, and they are also known as mucopolysaccharides. So, the one is more common and pretty well known is Hurler syndrome. The older name is gargoylism, which is not used anymore, but Hurler syndrome is again, this one is most severe and most common form and transmitted as autosomal recessive and caused by the deficiency of enzyme alpha 1 iduronate. Clinical features patient will have developmental delay, hepatomegaly, and progressively coarse features. And that's why the older name was gargoylism. It looks like gargoyle, as you can see in one of those big charts is in Europe. And the features also include kyphosis, severe degree of kyphosis, progressive stiffness of the joint, and they do have corneal clouding. This is a thing that you need to remember, the corneal clouding, and this is one of the diagnostic features of mucopolysaccharides disease type 1. And if you do the X-ray, you will see the dystosis multiplex and finding of dermatan and heparin sulfates in urine, and the enzyme deficiency can be demonstrated in WBC and skin fibroblast. Again, this has not come really that great, but this picture also clearly demonstrates that enzyme deficiency and end product. This is a nice picture of Hurler syndrome. You can see the corneal clouding, big tongue, and dysmorphism of the face called gargoyle type of face. But they are not mentally retarded. Hunter syndrome, this one has to be remembered because it is X-linked. As I have said, most of the metabolic disorder is autosomal recessive, excepting few. The one that I have discussed in the lecture, first one in lecture, is urea cycle defect, and that is X-linked. And here is another one, Hunter syndrome, which is X-linked. This is a favorite board question. I used to remember this by a little formula. Hunters are usually male, so it is X-linked. Well, that's how I remember, but you may have much better memory and will be able to remember it. So it is X-linked, mucopolysaccharidosis. Great point is no corneal clouding. So differentiate between the mucosaccharidase 1 and the Hunter is that They are X-linked and there is no corneal clouding. And clinical features, however, is pretty similar to Hurler syndrome, but it progresses somewhat slowly. Bone marrow transplant and a specific enzyme therapy is tried and used in some of the metabolic center, and this seems to have shown much better benefit in Hurler syndrome than Hunter. This condition is not mucopolysaccharidosis, nor it is a lysosomal storage disease. This is called Lesch-Nyhan syndrome. It is a defect in purine and pyrimidine metabolism. And this is also a X-linked disease. In 1964, a medical student Michael Lesch, and his pediatrician Nyhan in Johns Hopkins first time saw two brothers who presented to them with the features that I have discussed or described in this slide. This is due to the deficiency of hypoxanthine guanine phosphoribosal transferase. Enzyme deficiency is hypoxanthine guanine phosphoribosal transferase, and it is X-linked. So Lesch-Nyhan is X-linked, and that is something to remember for the purpose of your examination. They usually normal at birth, and slowly and gradually they develop compulsive, somewhat autistic, however more destructive behavior as the time progresses. They develop a spasticity of the leg, mentally challenged, and chorioathetoid movement. They have high uric acid, and because of that they develop gout etophi, and arthritis. Now, they are usually identified also, and in your board question, they have a very self-destructive behavior. They bite their own finger, and this could be very severe form. And next diagram I am going to show you, and this is one of the picture that I took when I was in metabolic rotation. And as you can see, this boy has bitten and more or less got rid most of his nail, and it's showing like this. But this picture I have got from a textbook, and as you can see, the degree of self-destructive and the biting has resulted in the absence of this part of finger. You can see very clearly these three. And then because of the biting, there is significant scar formation. So treatment of this condition is difficult, and they are usually hard to manage, and there are other metabolic conditions. As you know, the metabolic basis of the inherited disease, and this there are 3-4 volumes of the book, and what I have tried to do is put them together, the common one that usually comes in your exam, and it is believed or as I heard, that is about 1 to 2% of the question come from metabolic section, about 5% of pediatric board question come from endocrine section. So there are some of them that I have emphasized, and please follow them, especially the mechanism of transmission, X-linked varieties, and the who has got corneal clouding, who does not, who has serrated spot. So these are the things. If you just take my lecture and make it in a note form, and if you read that one before your test, or just for a quick knowledge, I think this will be very helpful. Thank you very much. See you in the next lecture, which will be pediatric obesity.